morning, everybody. Welcome to 10 Clinical Minutes on Decoding DX. This morning we have a great discussion on alcohol-associated hepatitis by John Gomez. Just a reminder, we are all M4s, so this information is not to be taken for medical advice, but is for educational purposes only, and reflects the views of the participants on this call and not any of our affiliated institutions. And before we get going, big thanks to Justin Kugel for the video editing support and his contributions with this project. So John, go ahead and take us away.
All right, so we're going to talk about alcohol-associated liver disease, particularly hepatitis, which is a small portion in the spectrum of this condition. So as a lot of you probably know, there is a spectrum of associated alcohol-associated liver disease. It can go from steatosis to steatohepatitis and a fibrosis pattern, cirrhosis, and that can go to decompensated cirrhosis, hepatocellular carcinoma, and sometimes end-stage liver disease. It's important to also note that the traditional name for steatohepatitis in clinical medicine was alcoholic hepatitis. And so if that is mentioned throughout this PowerPoint, or AH, which is how it's abbreviated in most medical literature, that is being replaced by alcohol-associated liver disease and alcohol-associated hepatitis, because that is a more patient-centric, more appropriate way to associate this, so we're not labeling patients in that way, because that is a great way to alienate your patients and labeling them. It's important to understand that alcohol use disorder is a very significant disease that it's really important to help your patients with. So just want to mention that. So we're going to focus on this steatohepatitis portion of it. And it's really important also to know about this, because not only can this particular condition cause cirrhosis, which is what you traditionally think of, it also can lead to essentially fulminant liver failure in an acute setting, which is the thing that we want to avoid in patients. What I want to talk to you about is kind of the steps that you go through. So when you want to clinically diagnose this and then grade it, and then think about, do I need to treat it with anything, particularly steroids? And then also kind of want to touch on the other things that you need to be thinking about when you see these patients, particularly in the inpatient setting, because that's usually where they'll be when they're having an acute hepatitis flare, essentially. So the main things to be thinking about for these patients, they'll have usually a history of alcohol abuse. This is something that's oftentimes will be known at the time of presentation. But if it's not, you'll see progressive jaundice, right upper quadrant pain, hepatomegaly, and fever. Those are the main things that you'll see. Oftentimes, this won't be a super obvious presentation overall. But you kind of have to have a high index of suspicion for that, and when you're getting labs. Also, if you see encephalopathy, ascites, other signs of liver failure, those should be red flags that this is probably a very bad situation. You also can see this in the setting of known cirrhosis or steatosis. So if you see stigmata of cirrhosis already, that doesn't mean they're not having an episode of hepatitis at that point in time. So when you see lab testing, the key thing that you're always going to see, especially in textbooks, is the AST to ALT ratio of greater than 2 to 1. Also, you'll see an ALT of less than 300. If you see something like a viral hepatitis, that'll be in the thousands, and some of those other drug-induced liver failures will be up in the thousands. So it's not going to be super high, but it's something that it won't be insignificant when you're looking on your CMP. You also see elevated GGT, elevated INR, T-bili, neutrophilia, and some other labs that you can get that kind of point you towards alcohol use if you don't know the history super well. Is a macrocytosis. The GGT is fairly specific for, or sensitive for, alcohol use. And then there's also a lab called PEth that can be used that just shows that there has been alcohol ingestion recently. That's not a lab that we use to say, like, get you or an aha, I saw that you've been drinking alcohol. That's a lab that can be used in conjugation with the patient, and they know that you'll be getting it. And so that can help with patients who you have been talking to in the past, so that you can help with abstinence. So that's kind of like a shared making decisions with your patients and helping them as they go. It's never to be used as I'm trying to catch you do something. It's important to know that, especially when you're thinking about, do I need to order this or not? Some other things, I'm not going to go through all of these, but just important to know there's lots of causes of acute hepatitis in the inpatient settings. Usually before you consult your friendly hepatologist about this patient, you should be ordering some of these labs, making sure you're getting viral serologies. Sometimes, think critically, say, have they just had an episode of shock, essentially, and so that's why their liver enzymes are going crazy high. The other big question is that people think, do we need to get a biopsy? And usually you don't need a biopsy. The only time you really need a biopsy is if you have some confounding measures that say, oh, this guy he has an extremely long alcohol use. We're concerned about alcoholic hepatitis, but he did just consume 3 bottles of Tylenol or something like a while ago, and we can't quite say, oh, this is exactly that. In those situations, you would be considering getting a biopsy just because you don't want to be treating this the wrong way, essentially. And so in those instances, that would be helpful, but for the most part, it's a clinical diagnosis. So once you say you have a patient who has alcohol-associated hepatitis, the thing you need to do is grade the severity. And so there's 3 different really tools, and each of them has their pros and their cons. The ones that you'll see in the hospital the most is MELD and MADRS. So MELD is the one that we all kind of know. It's related to transplant hepatology. It gives information on 90-day prognosis. It's usually used for transplant patients, but it's one of the easiest ones to get. That one, MADRS, that is based off of a clinical trial like close to 30 years or 20 or 30 years ago. And so it's been used the longest, but you'll notice that you need the PT. And I don't know what you guys know, but basically that's not something you see on a typical lab sheet. You don't see a PT, you see an INR. So that's a special one that you have to literally call down to the lab and say, hey, I know you just got me an INR, but I need the PT. I need a control for your PT so that I can score a MADRS. So that's usually not something that you'll see much in the hospital. And then the Lilly, it's similar to the MADRS, but it's based on data for a while ago, and they modeled it, and so it tells you what kind of prognosis you'll have in 6 months, and it also tells you your responsiveness potentially to steroids. So why these are important is because they give you mortality, and they also tell you how severe your episode of hepatitis is. So if you have a MADRS score of greater 32, or if you have a MELD score between somewhere around 18 to 21, that's not super set in stone. Those patients would be considered to have a severe episode, and those would be the ones who you would consider starting steroids in. Additionally, the Lilly model, the main use that it has clinically is that if you have an elevated score of greater than 0.45, that would mean that at 1 week of starting steroids, you're not going to have a response to that. And that's also a very, very poor prognostic indicator for mortality at 6 months. So, you shouldn't look at these patients and say, oh, they'll necessarily get better. If they're severe and these people will look very, very ill. And there is a high chance that they will die if they don't have a transplant. And so that's why you're considering steroids in these patients. So the mainstay of treatment overall, though, for these patients is actually alcohol abstinence and nutritional supplementation. So if you ask a hepatologist, what are you going to do for this patient, unless they're floridly looking like they're about to have fulminant liver failure, they had that severe picture, for the most part, they're just going to be abstaining from alcohol, and they're going to be adding nutritional supplementation and stuff, all your vitamins, just getting calories that aren't alcohol, because oftentimes these patients will be very nutritionally deficient. And so most societies will have like a greater than 21 kilocalories per day or something like that goal. And sometimes that even will require enteral nutrition supplementation. But if you do need to initiate steroids in those severe cases, the steroid of choice is prednisone for 28 days, 40 milligrams. It's important to note that it's prednisone because it's not prednisone because that requires hepatic clearance. So that is an important note you'll see on tests, that you don't want to give them something that they need hepatic processing essentially. And so prednisone is an active form, but there's a billion contraindications to starting steroids. So you don't want to get infections. You don't need to have AKI. You don't want to have any of these other underlying infections. And so for these patients, if you're going to start them, you will literally do like a sepsis workup for them, because infections are very, very common because they're essentially immunocompromised as well. So before you do anything, you will do a full workup. And in addition, you have to consider the social aspect and the likelihood for this patient to follow up, because these drugs are not benign. You don't want to send somebody out for essentially a month's worth of steroids and then them get worse and worse and worse, and you never hear from them again. So oftentimes that's one of the rate limiting factors for starting these in physicians. And when I was talking to hepatologists in the inpatient setting, that was their biggest issue more than anything, because that's a scary prospect to put an immunocompromised person who will not follow up with you and is probably not going to abstain from alcohol at this point in time. They aren't quite ready yet. That's one of those big things. And so if you do initiate it, you also need to be calculating the Lilly score in 1 week to see if you need to continue giving them more steroids, because if it's not helping, you're just immunocompromising them, you're not going to help their liver function. And then the other thing is, if they don't improve, liver transplant is about your only option. If you don't, otherwise you'll have to go the palliative route. There are other considerations and other drugs that have been investigated, but for the most part, it's just steroids or supportive care, essentially. So you can look at some of those other drugs. There's lots of studies that have been done on them, but they are not. They have not shown to be a lot of success overall. And then the last kind of considerations is there's other things that always happen when you have a patient with a history of alcohol use. So you want to watch for withdrawals. You want to make sure you're giving them proper nutrition. You want to make sure that they're not infectious when they come. And then you always want to be thinking about kidney failure. That hepatorenal syndrome is very common, and it can happen in the acute setting as well. And the overall most important thing, like takeaway from all this, is that the only thing that's really going to help, or not the only thing, but the most important thing, especially if this patient has not had a history of cirrhosis already, is alcohol abstinence. And it's really important to get addiction specialists involved with these patients, because alcohol use disorder is a very, very debilitating disorder. And it's really hard in the United States, especially because alcohol is everywhere. It's involved in every event. It's on every street corner. It's one of those things that you really need to get all of your colleagues involved who are really good at this, and also your hepatologists in general. This is what they do. They deal with transplant patients all the time, and so they have all the resources as well. Especially at KU, the hepatology liver transplant team has a lot of resources for those patients as well. So there's just kind of, if you want to ever look back at this, this is the Hepatology, American Society of Liver Disease, I think. This is kind of their algorithm for kind of what you need to do and be thinking about when you see these patients. But if you're ever thinking about getting steroids in a kind of patient like this, you probably should be consulting your hepatologist and have them start steroids. So, all right. That's a very quick rundown of hepatitis and the alcohol-associated liver disease.
Awesome. Thank you, John. Great presentation, and helpful to know when we need to consult our hepatology colleagues and what we should do before we give them a call. So thanks all for joining us. We'll see you on another meeting here for 10 clinical minutes. Have a good day.